and welcome to the Home of Medicine podcast with me, Dr. Amie Burbridge, and
you all know me now. I'm Ben Lovell. I'm a consultant in acute medicine in London and a medical educator.
Fantastic. Thank you again for joining us. It is a beautiful sunny day outside, and we are both so dedicated to the podcast that we are recording this on a sunny Friday afternoon. So, Ben, you've got a case for me today. So over to you.
Thank you. So this is a case that I encountered when I was, I think, about ST5, a medical registrar, about halfway through the training program. And it's a case that stayed with me ever since because it had such a profound impact on me and my practice, I suppose. And I want to lay it out for you now and see how you would navigate this case as well, because it is saturated with the stuff that we love to talk about, which is the clinical reasoning and why did my clinical reasoning take me in a certain way. So I'll give you the details of the case. The background was it was a night shift. I was the med reg in a small DGH in the outskirts of London. And it was about 4 o'clock in the morning. And I got a phone call from the gynecology SHO. And she said, look, I really need your help here. We've admitted a lady under the gynae team. She's a 34-year-old lady who's just miscarried a 20-week pregnancy and she's bleeding. So we've admitted her for observation. And well, she's paralyzed from the neck down. So I was hoping we could get a medical review, please. And I said, sorry, you mean she's newly paralyzed from the neck down or what? She went, well, no one's mentioned it before when she was admitted, but the nurses just asked me to see her because the patient wasn't moving. And the patient says she's paralyzed in both her arms and both her legs. And I said, and the patient says this is suddenly just happened since she came in. She went, I think so, but there's a language barrier. But yes, this all seems to be new. No one's documented it before. So I thought that was pretty intriguing. And I thought it was probably worth my going along to the gynecology ward and having a look. And of course, as you make your way there, you sort of turn things over in your head and go, what on earth could be going on here? Anything off the top of your head? Or how does that strike you, that sort of referral?
So I have to say, when you describe the case to me, it already starts to fill me with a little bit of anxiety.
Why?
I always get worried when I get called to gynae. It's an area of medicine, maternal medicine, I don't feel confident in.
Yeah.
And I genuinely think it's an area that I know we're trained more in now. Obviously, we have maternal medicine, which will hopefully be a specialty in itself, but it's not something that I feel like I was ever trained in. And that's my one concern. And secondly, new paralysis and neuro is also something that I feel is a weak spot of mine. So it's got two, I think, of my weakest areas. And also, you know, the individual has had a really emotionally challenging time with a 20-week miscarriage. That is a very, very hard to go through mentally. I have 3 children, and the thought of, you know, I've been pregnant, at 20 weeks, you are feeling movements. So to actually go through that as well is extremely, extremely difficult. So already there's so many things going around in my head. I guess
you're right in what you say about have you heard of the phrase neurophobia? It's this terror of neurological conditions in a lot of internal medicine trainees, because traditionally it's considered to be the hardest sort of presentations to untangle. And I think that a lot of people will resonate with what you're saying about acute neurology. It's hard. It's hard. It's harder than a pneumonia in a lot of respects. So I went along to see the patient, and on the way there, I was thinking, well, this is almost too bizarre to be true, but we'll keep an open mind and we'll go and see. And just to give you a bit of background, the medical registrar on core job was a job that I did for 7 years, and I really enjoyed it. And I know a lot of people dislike it, but it suited me really well. It suited my sort of temperament and personality, and I liked the new patients. I liked the take, I liked leading a team, and I always got good feedback in it. And people always said I did it well, and I liked it was a job that I enjoyed doing. And so, and I say this because I was quite interested in this case and quite intrigued as I was making my way there. And I was quite confident in that I had pretty good clinical nous, and I knew, how to make clinical decisions and to back them up. And I was quite a confident registrar. So I went to see the patient, and before I went in to actually meet the patient, I had a quick look at the Clarking notes, and I could see he was initially assessed by A&E with heavy PV bleeding, and then referred to gynae. Miscarriage was confirmed. The patient was seen before the night shift in the evening by the gynae consultant who recommended admission. And they'd said patient struggling to mobilize, a little note, and said it took the assistance of 2 people, including the gynecology consultant, to get the patient from a chair into the bed. But obviously no one had done a neurological examination because they weren't thinking of that at the time the patient was admitted. But I thought, well, hang on, here's a patient who walked into the department a few hours ago and admittedly with the assistance of 2 people managed to get from a chair to a bed. So that's interesting to know. And I went to meet the patient and I introduced myself, and the first thing I was sort of struck by was the patient was largely unflustered and unconcerned about this paralysis, and was more sort of concerned about the fact she had a runny nose and she wanted me to get her a tissue and a bit of a headache. And when I was sort of pressing her on, but you can't move your arms and your legs, is that right? It sort of shrugs, and yeah, I suppose so. It was a very strange sort of disconnect between the seriousness of the symptoms, which I thought was strange. And I asked her, and I said, can you move your arms and legs? She went, no, I can't move them at all. And they're numb, they're insensate. I can't feel them either. And I noticed during the conversation that she was quite still, but she would occasionally readjust herself slightly in the bed. And at one point, she did reach over and pick something up off the table next to her, slowly, but she did do it. And I thought, okay, so there is some movement here. And I did my neurological exam, which, as anyone knows, you know, doing a neuro exam, if you don't share a common language, is tricky. But when you train in London, in an international city, I'm quite used to doing neurological exams through language sort of barriers. And I've developed quite a nice way of nodding and pointing and gesturing and getting them to do the things I need to test. And I found that she reported complete sensory loss from, it looked like T3 down, but she did seem to sort of grimace and react when I was checking for sensation in her feet sometimes. But she did not move her legs at all, 0 out of 5 power. Her arms, with a lot of encouragement, I could get 3 out of 5 distally and a bit of movement at the shoulders. But then she put them down and say, they won't move, they're done, they won't move anymore. And so this was where I was sitting really. Now, the reason why I was quite in a bind here is because if I thought she had a true neurological emergency in my little district general hospital, what I'd have to do is arrange a blue light transfer to the nearest centre which had an MRI machine, which was a big deal to do overnight at 4 o'clock in the morning. I'd have to make a lot of phone calls. I'd have to leverage a lot of people into doing a certain thing and get them and persuade them to do it. Yeah, and it felt like a big deal to do. And the question I was asking myself was, do I blue light her over to the big hospital down the road for an emergency overnight MRI of her spine to look for a cord lesion? Do I have enough evidence to do that? And that's where I sort of sat down and paused. And I'm just interested to what you think you could or would have done in a similar situation like that.
So you've just asked yourself the question, do you have enough evidence to transfer the patient for look for a cord lesion? Do you have enough evidence not to transfer her? I guess so. Maybe flip it round and ask yourself, do we have enough to say actually we don't need to do that, rather than saying do we have enough that we need to do that? I don't know the answer to either.
Because what are we saying? If it's not a cord lesion, what is it? If it's not a neurological emergency, what is it? And I guess the only thing we could say is this a functional syndrome, which I think is, you know, you speak to some neurologists who will tell you that a functional disorder is a disorder of exclusion. You have to rule out organic.
Absolutely, yeah.
I've been in a lot of presentations now where neurologists who specialize in functional say, no, it is not as ordered. You can make a positive diagnosis based on your clinical assessment and save the patient from unnecessary investigation. I mean, as an ST5 without any neurology training apart from my PACES exam, I obviously am not or was not qualified to make a call about organic versus functional at 4 a.m. on night shift. But was I going to transfer her for a test for an organic problem, i.e. MRI spine? Or do I say this could be functional and therefore we'll let people come in the morning in daylight hours when there's a lot more senior decision makers around and we can get a consensus on what to do with it. And I really struggled with it for a while. What do you think you would have done?
So I guess, first of all, first of all, the question is the patient acutely unwell? So apart from a neurological signs and symptoms, she's had a 20-week miscarriage. So I want to know, observations, blood pressure, heart rate, is she still actively PV bleeding? So I guess from a gynecological perspective, is she stable to that end?
Yeah.
Has she had a hemoglobin drop?
She hadn't. She was really admitted for observation, but she was only spotting bleeding at the moment. Okay. She was hemodynamically completely stable and well. And also, when we sort of judge wellness in an inpatient, we use the vital signs, but we also use the sort of end of bed
yes,
test as well.
Absolutely. Yeah.
And my end of bed test was like, gosh, she looks all right. She was quite keen to go to sleep and put the whole day behind her. She didn't look like she was having any kind of health crisis.
So I think the first question is she acutely unwell, or is she hemodynamically unstable, which you've answered the question, and actually she's observations are fine, she's breathing, she's talking, so that seems reasonable. I'm trying to put myself in that position at 4 o'clock in the morning, because we know notoriously, having done lots of night shifts, that 4 o'clock in the morning, your cortisol level is in its boots. You are starving. You're reaching out for that sugar, that chocolate that's on the wards that you just want to eat. And you can't think straight. You can't make decisions because, you don't have the energy. And really what you would need to adopt in this situation is that type 2 thinking, where you really need to think about a case, ask questions. You can't use pattern recognition. And your ability to do that when you're exhausted and tired is really challenging. Although it's 4 o'clock in the afternoon now and I'm struggling to use my type 2 thinking. So she's hemodynamically stable. The question, is she stable enough to be transferred to a bigger hospital? Is she okay to go in the ambulance? And will the MRI help change my management plan overnight? So if I do identify a cord lesion, will that make a difference? Will I be able to sort that overnight? It is 4 o'clock in the morning. How long will it take for me to arrange all of this? Because it can take time. Will it be better to keep her, like you say? Do you know what I think I would do? And I don't know whether this is right, but my gut instinct at this moment is to have a conversation with the on-call consultant, because as a med reg, I think that this decision is too big for me. I feel that this decision is too big for me now as a consultant. But I think if I was in that position, I wouldn't transfer. I would keep her. And I don't know whether that's right or wrong. I haven't seen it's my gut instinct, and I would get a second opinion, I think.
So, yes, it's very interesting to hear you say that, because that exactly is the right thing to do, is to ask someone for help and say, this is a decision I have not encountered before. I cannot use my personal library of previous clinical experiences to guide me here because it's empty.
Exactly.
Have you got a library that I could use? Could I use your experience and your wisdom here? So why didn't I call my consultant? I sat there and I made a sort of list of pros and cons, and I wrote down, and she claims, well, claims is not the right word, but she is reporting certain symptoms which are not quite consistent with what I'm observing. Her symptoms seemed to come on suddenly, but they didn't seem to bother anybody previously. She saw an ED consultant and a gynae consultant, my superiors, before she saw me earlier, and they didn't seem bothered. Am I overreacting now? I thought also that arranging the transfer, what would the reaction be if I arranged the transfer and it came and she sort of went, whoops, my symptoms have gone away, or she gets out, walks out the ambulance at the other end, or they do the imaging, it's completely normal. What would I feel? Would someone come back and tell me off for making a bad decision and wasting people's time and resources? I thought, on the other hand, she's got new neurology. I could not get a reflex out of her at all. And I was banging away for a while, trying reinforcement and strategies, but I couldn't get a knee or an ankle jerk or anything. I thought, well, that's something you have to take seriously. And I think she did have some sensation. So in the end of the day, I thought, look, I don't think I've got enough rationale to activate this super duper pathway, which involves waking a lot of people up and mobilizing a lot of precious NHS resources. So I'm quite confident I'm going to wait. I'm going to hand this over to the day team. The full cavalry will be here in 4 hours. and ask them to reassess. And if the concerns persist, then they can do they can get an MRI in hours in our hospital, because that switches on again in the morning. We don't have to do that nighttime transfer. And I talked myself into this internally, and I decided that's what I was going to do. So I handed over at the morning handover, said, you could first think, can someone check this lady again over and just have another look at her, because she may well need urgent imaging today, but I didn't really feel I wanted to do it overnight. And I went home and went to bed. And I came in for my night shift the next night, and I went to the handover, and I said, say, what happened with that lady on the gynecology ward? And they looked at me and went, oh, Ben. And my heart froze, and they said, we MRI'd her this morning and she's had multiple spinal infarcts all the way down her cord. She's been transferred to the neurosurgical center for ongoing emergency treatment. And my heart just fell into my shoes. I wanted to be sick. And I then had to do a 12-hour med reg on call shift overnight, completely gaga with anxiety and regret and remorse and sort of self-loathing, really, for making such a terrible judgment call. And it was a long time till I was able to talk this out. Well, it was a few days until I was able to talk it out with my educational supervisor and work out what had happened there. Had I made such an egregious error that I caused harm, and how did I come to do it? And I've never had a situation like that before or since, which affected me so emotionally. And it's very difficult to be the med reg, of which there was only one of you out of hours running the show, and to be so profoundly emotionally affected by something that you cannot concentrate on what's going on in front of you. And it is such a horrible state to be in. And I don't know that something like that has happened to you, anyone who is listening, where you're trying to work, but you cannot focus because of any kind of internal distraction, which just causes your mind to go into chaos.
I'm just, when you said you went into the night shift and there was that look between the day reg and whoever, and they were like, oh, Ben, this happened. I've been in that situation where my heart sank and I felt sick, and I've done, it's a different case, but I've also, I made a medical error, and it still lives with me now. And I still, when you said that, you felt that sort of, you almost feel like you've had a punch in the stomach. And I felt that then when you were telling me that story, because I've been there and it's utterly devastating. For what it's worth, I don't think you made a medical error. By the time she transferred over to that hospital, had the scan, would it have changed what was going to happen? I don't know. We're never going to know, are we? Because...
Well, I had a debrief with my supervisor that the whole situation became... it wasn't an SUI, because it wasn't like something gone horribly wrong, but there was a lot of feedback going on. And she said they've been in contact with the neurology center she went to. The MRI wouldn't have made a difference if I'd sent it overnight. But for some reason, that was very cold comfort to me. I'd lost a lot of my confidence and my mojo, knowing that even though I hadn't changed the trajectory, the established infarcts were there. I had lost a lot. I said at the beginning that I was a med reg who enjoyed his job and was quite confident, and I got good feedback. I was well thought of,
Yeah, absolutely.
I felt like that had been completely taken away, and I didn't know what I was and who I was, and if I was any good suddenly anymore. And part of the reflection and teasing out my thinking process, my consultant said, so just tell me again the case. And I said it out to her, and she said, so Ben, if you had called me overnight and said, I've got a patient here with acute onset patchy sensory loss from T3 down, complete paralysis 0 out of 5 of both legs, absent reflexes on both sides, and 3 out of 5 power in the arms, which is new onset. And I would have said, Ben, put down the phone and call the MRI, get this MRI done out of hours. And when I was saying it out loud, I went, do you know what, you're right. I would have done if I said it out loud. I think even the action of talking that out loud to you, I would have interrupted myself and said, sorry, why am I even bothering you with this? I clearly need to, this woman's got a neurological emergency. And one thing I always say to people now when I'm teaching others, or I'm saying to say it out loud to someone else, because sometimes you'll hear it and you'll suddenly come to an answer just by hearing it out loud. And that is what happened to me in that instance. And I think if I had said it out loud to someone else, they would have said, Ben, what are you talking about? Or I would have said to myself, you've got to get this, you can't ignore these signs. You can't assume functionality in this case,
That's really interesting, because I'm just going to bring something up here. So when you said to me what you said to your supervisor, that I've got a 34-year-old lady, patchy sensory loss, all these changes, my first instinct was like, she needs an MRI now. What are you thinking? However, when you first told me the story, you framed it differently. So we really have to think of the framing effect here, which is another cognitive bias which we use. The way that you, for want of a better word, sold me the story at the beginning of the podcast is very different. So 34-year-old, 20-week miscarriage, she was paralyzed, there was a language barrier. You went to see her and actually she looked all right at the end of the bed. She was, and I'm thinking, this is clearly functional. That was how it was sold to me. And I think we do that quite often in clinical practice, is we tell a story because we already know what answer we want to get.
Mm-hmm. Yes. I think also when people say to me, I've got a case here of pyelonephritis, it's very hard for me to then not think appendicitis or something else like that.
Absolutely.
Given up front. And there's something about discovering details bit by bit. For example, when you're examining or assessing a patient, as opposed to getting a bullet point of 3 sentences at the end, which has filtered out all of the more hazy stuff and the salient indicators. So when you say, I've got a patient here, acute onset sensory loss with a sensory level, 4-limb paralysis, that's different to going, and then I discovered this, and then I tested this, and the coordination was fine. Putting it all together packs more of a punch.
It does,
and
absolutely.
It makes me wonder, you can probably make anybody think anything in healthcare if you just say it in a certain way, which I think is good and profoundly dangerous. But how many people have packaged up a summary of a case in a certain way to get a scan that they want, if they think it sounds more compelling? For example, and I don't think I'm blowing any trade secrets here. I think radiologists know we do this, for example, or to get a referral or a review for someone we want. How do we frame the patient to sort of generate a reaction in our listener? We do it differently. Where do we learn this? We've all picked it up, maybe just individually, or by watching others.
Well, do you think that's life though? So I'm just thinking we do it at work. Particularly, I think a typical one is when you're trying to get that CTPA done in A&E, and you're trying to sell this clearly huge PE, which actually probably isn't, but you're selling it. But actually, I think we do it in life, don't we? My children do it to me all the time, and I think you tell a story and they want to get a reaction from me. They embellish things, and that's what we do. I think actually it's life, and I think it's storytelling, and I think we learn that from a very, very early age, from just reading Harry Potter, from reading Roald Dahl. We're telling a story. And I wonder, because I know you're a very passionate, avid reader, I wonder whether some of the way that we try and frame patients is actually from what we read and how we read, and and our personalities as well, I think probably has an impact on it. So I don't think we just do it in work. I think we do it in all walks of life, and I think
it's interesting what you said, when you said the word you used, said when we're trying to sell. So we have something to sell, and are they buying? I'm not buying that. It's like, well, how do I resell it? How do I rebrand this to make it more attractive to the buyer? Which is when you look at it, or
it's awful, isn't it?
Outside healthcare was listening to this, like, it sounds absolutely crazy, doesn't it?
Yeah.
If someone needs a scan, they need a scan. Why have you got to sell it? And it's interesting how we never explicitly teach people to do this or encourage it, but it seems to be something we all sort of adopt, and I think everyone listening is going to recognize. So it's something that we do, and maybe it is part of it. Human beings are storytellers. That's what sort of separates us. We all like to create narratives and histories and stories, and maybe it just comes from natural storytelling instinct of being the apes that we are.
Very interesting.
Going back to what we said as well about what were the barriers? What were the barriers for me making that phone call to the consultant? And I really, I really went over this. I think a lot of it is fear of bothering people unnecessarily. And I'm talking about this happened in 2015, maybe. And I don't know how much has changed in that time, but I didn't really come in a culture of calling for help overnight, calling the consultant overnight in medicine. And I think things maybe have changed now, but if you compare us to, for example, the intensivists who will always call their consultant, in medicine, it's not something that's always the done thing to do. So I think I was working within my sort of received cultural norms of, well, we rarely bother the consultant at 4 o'clock in the morning just for a clinical question. Because if you ask a question, that must mean that you are incapable.
I was just about to say, I used to feel it was a badge of honor not calling the consultant, because it was like, well, I don't need to, because I know, I mean, I now realize I don't know everything. I'm sure as a med reg at some point, I felt like I was invincible and I did know everything. So I used to, love telling other people, oh, I never call the consultant. I don't need to. That's bonkers. I actively encourage people, I want them to ask me questions. I want them to bother me.
Yeah.
But it was seen as she's the reg who never phones, which
doesn't need to phone, doesn't need to ask.
Exactly.
I remember consultants saying to me when they were going home, "Is have a good night shift. Feel free to cope. Don't." And it was a badge of honor not to ask for help. And I hope that is less of a cultural barrier now in the world of medicine as it was when I was the registrar. When I'm the consultant on call now, I do get called, but it's not often. But I do sometimes get called. I think more than maybe this was the norm 10 years ago. And one thing that happened to me after this case was I developed quite a strong avoidance, if that's the right word. When you have a really negative experience and you just want to never happen again. And I developed this sort of horror, and it wasn't an avoidance of neurology. It wasn't avoidance of, seeing patients with who don't speak the same language as me. I developed this really strong aversion to maternal medicine and gynecology. And you said at the very beginning that it's something that was never taught, and it was a bit of a blank spot for you, and it was for me as well. But I sort of went into a place afterwards where every time I got a phone call to go to the gynae or the obs ward, I would actually I'd feel sick, and I'd say to someone else, "Oh, can you go and see this patient?" I lost my mojo completely in that area. And I was talking to my supervisor saying, I can see this is happening to me and I don't know what to do with it. And it made me wonder, like, how do you conquer demons like this in medicine?
Gosh, we all have them, don't we?
We all have them. Yeah.
We do. And after I had a really challenging case, which, I ended up, I'm sure we'll discuss it on one episode, but I ended up taking a bit of time out of work, and I don't know about burnt out. I don't really like that word, but, I was broken, to be honest. And so I guess the way that I conquer my demons is to face them. I've been in a very similar situation where as I talked about before, and I'm sure we'll talk about it, a case on the podcast in the future. And I ended up taking time out of work because I was broken and thought I was rubbish at everything I did. And mine was, it wasn't really the clinical side of it, I guess, that I was worried about, because I felt like some of it I can read about abdominal pain, but it was the effect that it had on, I guess, my ability to take history, to examine properly. And it was really, I thought, what I was good at, I couldn't do anymore. And it was all about, I felt like I had to hide, because you couldn't admit that you'd made a mistake. And it was about, I was no longer this great registrar that everybody thought I was actually pretty crap. And that was really challenging for me. And I think I did a weird thing, actually, in that I started to tell everybody about it. Now, I don't know whether that was the right thing to do or the wrong thing to do, but I just told everyone, because I actually felt if we talk about mistakes, we learn from them, and it makes medical errors, not more acceptable. That's not the right word, but we need to talk about them. So you didn't make a mistake. You were in a challenging situation. It was 4 o'clock in the morning. You were on your own. You were exhausted. You were dealing with medicine in a situation in gynae that's not something you're familiar with. It's a systems error, isn't it, that we're put in that situation? I don't know.
Well, you said a couple of times, and I think that what you like to do is meet it head on. And it's funny because as a teacher, as a medical educator, I always say, if you're struggling with a subject, teach it. So
Yes.
An expert. So teach it to someone else. If you cannot get your head around the different glomerulonephritis, then prepare a teaching session on it, and you will be the glomerulonephritis expert. So I thought, well, what am I going to do? And by the way, I'm not advocating everyone does this. And a lot of people listen to this and say, well, Ben, you overcorrected there slightly. But I decided to sit the diploma with the Royal College of Obstetrics and Gynecology, do my BRCOG. And I did. And it was an absolute breakthrough for me. I always quite liked studying.
Wow.
because I'm quite geeky. I hadn't done an exam for yonks. I thought, I'm going to do this exam. GPs do it, I know. Lots of other people do it. It's a DRC, it's open to everybody. Brilliant. And I did it, and I studied for it. I became an expert in medical, well, in gynae, you know, in medical complications thereof.
Amazing.
And I did the DRCOG. Got a few more letters after my name. Fantastic. But I really
Brilliant.
put that demon to bed. And I am absolutely not advising anyone listening that if there's an area of medicine you struggle with, you're frightened of, is to sit an exam in it. But I'm saying that for me, if you have to force yourself to get good somehow. And this is how I chose to do it. And that's the story of how I became Ben Lovell DRCOG. But it was actually a really for me to get over that horrible avoidance behavior I was developing and I did not like in myself.
I think that's one of the best recoveries from a medical error I've ever heard, because, you know, and I think you handled it brilliantly. And you, like you say, you know, the sad thing is I'm thinking, do I need to do DRCOG? Oh my God, I'm going to log online now and do the exam. But I guess, you know, and I think that's what, you know, what I did with me is I actually started to tell everybody about medical errors. And I remember I decided to talk about it at the Royal College of Physicians. I was like, why not? Let's just face it head on. Let's not go small scale. Let's go full pelt RCP, which is what you did, you know, and that's why I'm here today doing this podcast, because of that medical error. And it's through a weird, strange, you know, route. That's why I'm here today. But like you say, you know, I don't think everybody should do a podcast or sit the DRCOG, but... No.
But there's usually something in that family of behaviors that I find quite useful, which is forcing yourself to become immersed in the problem that you've identified, and then getting really, you know, good enough for you to work your way out of it. I think if you continue to avoid it, it leaves a scar. And I think it leaves a scar on how you practice as well, but it also is deeply unpleasant on sort of an emotional, psychological level. And you kind of have to do something about it. And like you say, talking about mistakes wasn't the norm when I was a junior doctor. Sorry, I'm trying to run a find and delete program on my brain and stop saying junior doctor. When I was a doctor, a trainee doctor, but we didn't talk about it because it was admission of guilt, you see, and you could get in trouble. But I am inspired by you, and I've seen lots of other people at conferences talk about the last SAM conference. There was a whole session about mistakes I made. And these three amazing, very talented, very professional consultants talked about a mistake. And I found that really inspiring. And here I am talking on an international podcast now about it, which I never thought I would do when I was in the middle of that situation.
Absolutely.
And I remember my supervisor saying to me, going, one day, Ben, this will be the making of you. And one day you'll be talking about this to help somebody else. And I was like, no, I am not talking about this. This is going in the cupboard. This is under the title of shame, and it will never be brought out again. And I did. And now I'm a supervisor, an educational supervisor for lots of fantastic younger doctors, and they have medical errors. They make mistakes, or they're in a situation like this, and I bring them this story. And I say to them, well, here's what happened to me. And I say to them, do you know what? One day you will be in my seat and you'll be telling your own supervisee that this will be the making of them. I promise you. They go, no, it won't. This is awful. I say, I bet you anything it will. And you will make your peace with this if we do this carefully. And then you will use this to show how you got to the journey of being the amazing doctor you will end up being.
Yeah, I completely agree. I'm just looking, there's a quote that somebody said that every doctor has is it René Lerick from Lerick's phenomenon? Every surgeon carries with himself a small cemetery where from time to time he goes to pray, a place of bitterness and regret where he must look for an explanation for his failures. And I love that, because I think that says exactly, you know, we all have our own cemetery. It's a horrible word, isn't it? This where we have made our errors, but actually we need to talk about that with others, and we need to be open and honest, which is what you've done brilliantly today. And I hope this prompts others to be open and honest and talk about it. And what it's prompted me to do is to think, I am neurophobic. I'm petrified of it because I'm no good at it. You know, I need to go into some neurology clinics. I need to go and sit in on them. I need to stop avoiding the neurology patients who come into MDU because I'm scared of messing it up, and I need to face it head on, which is exactly what you did. I think that was
said and done, isn't it? But I think it has to be done.
Yeah, and you know, we all have areas which we're comfortable in, and then we all have areas which we're uncomfortable in. And I think I'll happily spend a whole day working in same day emergency care. I love it. That's, but then you put me into, ward rounds on the people who've been in for 24, 48 hours. I struggle and I avoid it. So maybe I actually now need to, go into my area of my uncomfortable zone, I guess.
I think also it's about reflecting on things, because when you have a catastrophic event, which is what that was to me, I could have had a not so good supervisor who just said, oh, let's just forget about it, rather than one who challenged and encouraged me to reflect. And reflection is, a lot of is very heavily criticized in medical education because a lot of it's enforced. You must do 5 reflections in your portfolio, and 4 reflections don't work. They're null and void. They have to come spontaneously. They have to come from you. But and a lot of people think it's worthless, but in fact, reflection can prevent you from ruminating, and reflecting seems to result in more positive outcomes rather than just rumination and avoidance, which can fester. So if anyone is listening, I would just say, reflection is a very powerful tool, which can be quite transforming when you go through a very stormy period and your temptation is to lock it away and never go near that situation ever again. It won't work. That doesn't work. Not in general medicine anyway. And
it's sort of, I used to do that years ago because that was the done thing, wasn't it? To lock it away and to close that door and to never meet it again because it was embarrassing, it was shameful. And, the culture in the NHS was different. It has changed now. We are becoming more open and honest. We're becoming less of a blame culture. We are addressing errors differently, more as a systematic approach rather than an individualized approach. And it's certainly, I think, for those of us who are supervisors, I really like taking my supervisees for coffee, sitting them down and just saying, how are things? Not focusing and asking them outright, but eventually the conversation does go to that because you're putting them in a psychological safe space. And I think that's really important, that they feel safe to talk about these things.
And that's why the educational supervision is one of my favorite parts of my jobs.
Really? Oh, yeah. It's when it's done well, it's transformative, isn't it?
Yeah.
Absolutely. And when it's done badly, it can be very negative and have a negative impact.
Yes, and I think it is done badly across the board more often than any of us would like, but maybe that's a separate topic of conversation.
Yeah, that's another podcast, is educational supervision, isn't it? And how you can do it well. I'm sure I've got loads to learn from you on that particular topic. Okay, so I think we need to, I guess, what do you want our listeners then to take away from this podcast? What things, 3 key elements?
I think if you're in an absolute quandary decision making out of hours and the buck has stopped with you, saying it out loud, ideally to another human being, but not even always, saying it just out loud so your own ears can hear it rather than just be the soup of thoughts inside your brain, can often help you come to a solution. And I would say that if you are a registrar or any training grade doctor, the reason why that there is always a consultant on call is for exact situations like this. So you should always feel empowered to get a second opinion in a situation like this. And I guess the third thing would be, when something like this happens to you, resist the temptation to bury it, and have a think about what factors led you down to make this decision that could prevent it from happening the next time. I'm talking human factors here. I'm talking what clinical biases maybe did you have? Because when you see them, when you bring them to light, it can actually be quite transformative. And I think that's a really important part of becoming a mature, reflexive practitioner and a medical professional.
Yeah, I completely echo that. I think, in the asking for help, now it's something as a consultant now that I actually now ask for help from other consultants if I'm stuck. So I've seen patients and I'm like, I really don't know what's going on. And I will sometimes ask a colleague and I'm like, do you mind seeing this patient for me? And they're like, but you've seen them. I'm like, I know, but I don't know what's going on. So sometimes I wouldn't have done that because it's admitting that I don't know something, but now I'm much more, I'm much more open to asking for help, reflecting, absolutely. And I think the awareness of that framing effect for me as well is that was really powerful at the beginning when you told me the story of the patient and how you set the scene, and then how you then told it, your supervisor told it back to you in a very short 3-line sentence, and it completely changed the the story.
Yeah.
And I think that's really, really powerful as well, and really important. Yeah. Thank you so much.
A pleasure as always. Thank you so much for having me again.
That was incredibly enlightening and quite deep actually for a Friday afternoon. So thank you to everyone out there for listening. If you like the podcast, you can listen on Apple, you can listen on Google Play and Spotify, and please, please, please rate and review us, because the more that you rate it, basically more people will be able to identify and spot the podcast and listen to it. If anybody out there has any cases that they think would be good to discuss on the podcast, please get in touch with me. You can contact me at amy@efimacademy.org, or you can tweet me at Amy Burbridge. Thanks for listening. Goodbye. You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.